Welcome to the Deep Dive, this show where we take the source material you've shared with us, plunge into its depths, and really extract the core knowledge, those surprising facts, and the vital context you need to truly get a handle on the topic.
That's the goal, really unpack it.
Today we're embarking on perhaps the most fundamental and frankly one of the most, mind-blowing journeys in all of biology. The incredible process of human development.
It really is something else.
We're going all the way from the earliest moments after conception, through that intricate unfolding inside the womb, the really dramatic transition of birth, and then into those critical first months and years of life.
A huge span of time and change.
You've given us some dense but absolutely essential excerpts from a physiology text. They walk us through fetal growth, the immediate period after birth, that adjustment phase, and the initial steps of childhood growth.
Yeah, it's solid material.
And this isn't just about, getting the facts. It's about understanding the how and why behind this miracle at a level that gives you a real physiological grasp. The kind of understanding where you feel like you've mastered the subject.
That's right. Forget just skimming the surface. We're going to unpack the complex physiological principles that govern this whole transformation. We'll highlight the ingenious biological solutions nature uses and trace the essential milestones that mark this remarkable passage. It's really about seeing the intricate machinery at work.
Think of it as gaining a professional level appreciation for the engineering of a human being, right? Built one physiological system at a time, and then radically reconfigured for life outside the womb. We're diving deep into the blueprint, the construction, and the real-time adaptation required.
Exactly. It's a story of rapid growth, delicate balance, and profound change. We'll move beyond just listing facts to really understanding the functional significance of each stage in each developing system, so you don't just know what happens, but why it matters.
All right, let's roll up our sleeves and truly unpack this, starting at the very, very beginning. Fetal growth and development.
Okay.
So when we look at the absolute earliest stages, right after implantation, one of the most counterintuitive points from the source material is how the support system seems to explode in size before the baby itself really does.
It is fascinating, isn't it? The placenta and the fetal membranes, those critical structures that establish the connection to the mother and create the environment for the fetus, they grow far, far more rapidly than the fetus itself during those initial weeks.
Really?
Yeah, it's like the infrastructure is built almost to scale before the main occupant is much more than a, microscopic cluster of cells.
And that microscopic part is key. The source really emphasizes just how tiny the fetus remains. For the first 2 to 3 weeks after implantation, it stays almost, if not completely, microscopic.
Think about that for a moment. You have this elaborate structure of placenta and membranes developing, but the actual embryo is still at a scale where you need a microscope to really see it distinctly for several weeks. It just underscores the establishing that lifeline, that nutritional waste exchange pathway with the mother is the absolute first physiological priority.
Makes sense.
Without that, none of the subsequent development can happen.
But then things shift, and growth starts to accelerate dramatically. How do we even track this growth as it picks up pace?
Well, the source describes tracking it initially by length. After that early microscopic period, the increase in length becomes almost proportional to age for much of the gestation. It's a relatively steady, sort of linear increase week by week.
The text gives us some concrete numbers to latch onto, which really helps visualize this. By 12 weeks, which is roughly the end of the first trimester, the fetus is around 10 centimeters long. That's already a significant leap from microscopic.
Right. From barely visible to about 4 inches in just a couple of months. Then by 20 weeks, which is halfway through the pregnancy, we're looking at approximately 25 centimeters, about 10 inches.
And by term, 40 weeks, the average length is about 53 centimeters, or around 21 inches. So you see that fairly predictable, almost proportional increase building over the months.
But while length gives us one perspective, weight tells a very different story, especially as pregnancy progresses into the later stages.
That's because weight isn't a simple linear increase like length. The source points out that weight increase is proportional to the cube of the length.
Yeah, the cube.
And since length is roughly proportional to age, weight increase is almost proportional to the cube of fetal age. What does that cubic relationship mean in practical terms?
It means weight gain starts very, very slowly and then accelerates exponentially. It remains minuscule during the first 12 weeks, just like length. It takes until about 23 weeks. That's well past the halfway point, almost 5.5 months for the fetus to even reach 1 pound.
A full pound. only at 5.5 months. Wow, that really drives home how much of the growth happens late. So it's in that last trimester where the weight gain becomes incredibly rapid.
Absolutely. The source gives us milestones just for that period because it's so critical. 2 months before birth, around 32 weeks, the average weight is about 3 pounds. 1 month before birth, around 36 weeks, it's jumped to 4.5 pounds.
And by the time of birth, at term, the average is 7 pounds. That's doubling the weight in the final 2 months, almost.
Pretty much, yeah. This rapid weight gain, much of which is fat accumulation, is absolutely vital. It provides the energy stores and insulation the baby will need immediately after birth.
Okay.
The source mentions the normal birth weight range can be quite broad, from maybe 4.5 pounds up to 11 pounds in normal full-term infants. So while 7 pounds is the average, there's a healthy variation there.
So we have this blueprint laid down incredibly quickly, followed by steady length gain, and then this explosive weight gain in the final months. What's happening internally during all this? Let's talk about the development of the organ systems.
This is where the rapid initial phase is truly astonishing. The source highlights that within just 1 month after fertilization, the gross characteristics, the basic layouts and shapes of all the different organs have begun developing.
All of them: lungs, heart, brain, kidneys, gut, starting their formation within a month. That's incredibly rapid anatomical differentiation.
It is. The foundational structures are mapped out with incredible speed. Then, over the next 2 to 3 months, the details of most organs are filled in. By the end of the first trimester, the fetus has something that recognizably resembles a miniature human with all its organs in place, at least superficially.
But, and the source makes this crucial distinction, just because the organs look roughly similar to a neonate's after month 4 doesn't mean they're ready to function independently, right?
Exactly, that's a key point. The cellular development and maturation within each organ is a much longer process. It requires the full remaining 5 months of the pregnancy for that cellular finishing work to be completed.
Finishing work, like what exactly?
Well, it means proliferation of specific cell types, development of specialized cellular machinery for that organ's function, and establishing the complex internal architecture of tissues, the fine details.
And critically, even at birth, some structures are still not fully mature. The source specifically points out the nervous system, the kidneys, and the liver.
Yep. These are vital systems that continue developing after the baby is born, which explains some of the challenges neonates face, the vulnerabilities they have.
Let's dive into some of these specific systems and their developmental timelines. The circulatory system is often cited as one of the earliest wonders.
It really is. The source tells us the heart begins beating during the 4th week after fertilization.
4 weeks. That's amazing. The embryo is still tiny, but it already has a functioning, albeit simple, circulatory pump.
And that initial rate is quite slow, around 65 beats per minute. But it steadily increases throughout the entire gestation, reaching approximately 140 beats per minute right before birth. That rising heart rate reflects the increasing metabolic demands of the growing fetus.
And alongside the heart, the blood itself needs to be formed. The creation of blood cells also follows a fascinating sequence of locations.
It's a journey across different tissues. Around 3 weeks, you get nucleated red blood cells, which are precursors, starting to form in the yolk sac and parts of the placenta.
Then, just a week later, at 4 to 5 weeks, the fetus starts producing non-nucleated red blood cells, the more mature form we have from its own mesenchymal tissue and the lining of its developing blood vessels.
At 6 weeks, the liver takes over as a major site of blood cell formation. Then, in the 3rd month, the spleen and other lymphoid tissues join the effort.
And from the 3rd month onwards, the bone marrow, which will be the primary blood-forming organ for the rest of life, gradually takes over as the main source for red blood cells and most white blood cells.
Though the lymphoid tissues continue focusing on lymphocytes and plasma cells, the immune cells.
The source also highlights iron accumulation, which is happening alongside this blood formation starting as early as the 3rd week. Iron is essential for hemoglobin, right? The oxygen-carrying molecule.
Absolutely. And the mother's role is vital here. Even before implantation, her uterine lining has iron concentrated in it, and the early trophoblastic cells can actually ingest this iron to supply those very first red blood cells. It's quite ingenious.
And what's really crucial for afterbirth is the iron storage.
Yes, that's a critical physiological adaptation. The source notes that about one-third of the total iron in a full-term fetus is stored in the liver. This isn't just passive storage, it's a deliberate reserve usable by the neonate for several months after birth to continue building its own blood supply, especially when milk might not provide enough iron initially, like a little backup supply.
Smart. Now let's think about the respiratory system. Obviously, a baby inside the womb isn't breathing air.
Correct. There's no gas exchange with the outside world happening via the lungs in utero because the amniotic cavity is filled with fluid, not air. However, the source points out the fetus does make attempted respiratory movements. Practice breaths, kind of.
Practice breaths. When do those start?
They start around the end of the first trimester. The source says they can be triggered by tactile stimuli, but notably also by fetal asphyxia, a temporary lack of oxygen. This shows the respiratory center is already sensitive, even then.
But, and this is a bit of a physiological mystery highlighted by the source, these movements are largely inhibited during the last 3 to 4 months of pregnancy.
Yeah, the text says the reasons for this inhibition are unknown. We don't fully understand why they stop practicing, so to speak.
And yet there's a very clear and important purpose for this inhibition in later pregnancy. It prevents the fetal lungs from filling up with fluid that isn't just amniotic fluid, but potentially also meconium.
Exactly. Meconium is the baby's first stool, and it gets excreted into the amniotic fluid during the last months. You don't want the lungs full of that.
So instead of air or debris.
Instead, the lungs are kept filled with a small amount of clean fluid secreted by the alveolar epithelium itself right up until birth. This fluid environment isn't just passive, it's actually crucial for normal lung development, allowing the airways and alveoli to expand and grow properly.
Moving on to the nervous system, another area that undergoes rapid development, but is famously not fully mature at birth.
Right. The basic wiring for reflexes is established quite early. Most reflexes involving the spinal cord and the brainstem are functional by the 3rd to 4th months of pregnancy. So, simple responses to stimuli are possible.
But the cerebral cortex, the part for higher-level thinking, consciousness, complex behaviors, that's still very much in the early stages of development even at birth, still under construction.
And a critical process for efficient brain function, myelinization, where nerve fibers get an insulating sheath to speed up signal transmission, isn't complete for some major brain tracts until about 1 year of postnatal life.
So the pathways are there, but they aren't running at full speed yet.
Pretty much. This immaturity is reflected in brain size, too. At birth, the infant brain is only about 26% of its adult mass. It reaches 55% at 1 year and is nearly adult size by the end of the 2nd year. Rapid growth early on.
The source also notes a structural limitation kicks in later. The closure of the fontanelles, those soft spots, and the sutures of the skull restricts further brain growth, allowing only about 20% additional growth after the first 2 years. The skull essentially sets the final size limit.
Right, the box gets closed.
And this neurological maturation is what underlies the visible behavioral milestones we see in babies. The source references a chart, figure 84-9, used clinically, showing things like suckling, smiling, vocalizing, controlling the head and hands, rolling over, sitting, crawling, grasping, pulling up, standing, and eventually walking.
These aren't just learned actions. They represent the nervous system developing the capability to control the body in increasingly complex ways. Each milestone reflects a new level of neural maturity.
The gastrointestinal tract also gets a lot of practice in utero, doesn't it?
It does. By mid-pregnancy, the fetus starts actively ingesting and absorbing large quantities of amniotic fluid.
Swallowing amniotic fluid.
Yeah, it's like a training exercise for swallowing, digestion, and absorption, getting the system ready.
And by the last 2 to 3 months, the GI tract's function is approaching that of a normal neonate. It's getting ready for its main job outside the womb, processing actual food.
And during those final months, the source mentions, small quantities of meconium are continuously formed in the GI tract and excreted into the amniotic fluid.
And meconium is?
It's described as a mix of residue from swallowed amniotic fluid plus mucus, shed epithelial cells from a gut lining, and other excretory products from the GI glands. It's sterile in utero and usually passed as the first stool after birth.
What about the kidneys? They're often mentioned as another system that's not fully mature at birth.
That's accurate. Fetal kidneys begin excreting urine during the 2nd trimester. And that fetal urine is actually a major player in maintaining amniotic fluid volume. It contributes about 70% to 80% of the fluid.
So if a fetus has severely impaired kidney development, that can lead to a significantly reduced volume of amniotic fluid, a condition called oligohydramnios.
Exactly, and that can be very dangerous for the fetus, restricting movement and lung development.
But even though they produce urine, the control systems aren't quite there yet.
Right. While they produce urine, the crucial renal control systems for maintaining body fluid balance, electrolyte concentrations, and particularly acid-base balance are almost non-existent until late fetal life. Full functional maturity of these complex regulatory abilities really doesn't happen until a few months after birth.
That's key, right? That vulnerability.
Absolutely. This is a key reason why neonates are so vulnerable to fluid and electrolyte imbalances. Their kidneys just aren't fully equipped to handle major fluctuations yet.
Let's shift gears and talk about fetal metabolism. What fuels all this incredible growth and development?
The main energy source is glucose. It's constantly transferred from the mother's blood across the placenta. The fetus is essentially running on mom's fuel supply.
And the fetus has a remarkable capacity for storing energy reserves, particularly fat and protein. Interestingly, much of the stored fat isn't just passively absorbed from the mother. A significant portion is synthesized by the fetus itself, using that glucose as a building block.
Beyond glucose, there are specific metabolic considerations for essential elements and vitamins needed for complex structures. The source specifically highlights issues related to calcium, phosphate, iron, and certain vitamins.
Calcium and phosphate are obviously critical for building bone. How does the fetus accumulate these?
The source has a figure, 84.2, showing this accumulation. It's significant throughout gestation, but notably, about half of the total amounts of calcium and phosphorus accumulated by term happen in the last 4 weeks of pregnancy.
Half in the last month.
Yeah.
Wow. That coincides perfectly with that period of explosive weight gain and rapid ossification of fetal bones we discussed earlier.
Exactly. Earlier in pregnancy, bones are relatively soft, mainly a cartilaginous matrix. Ossification, the hardening with calcium and phosphate, typically starts after the 4th month, but it accelerates dramatically in the final weeks, laying down that mineral framework.
The source points out that the total calcium and phosphate the fetus needs, while crucial for the baby, represents only about 2% of the quantity in the mother's bones. It's a minimal drain on her reserves compared to the calcium demands of lactation after birth.
Right. Pregnancy is less demanding in that specific way than breastfeeding is later.
Iron accumulation is another vital process, and that figure shows it accumulating even more rapidly than calcium and phosphate.
And again, most of this iron is being built into hemoglobin for those developing red blood cells. As we mentioned, hemoglobin formation starts remarkably early, around the 3rd week, using iron ingested by the trophoblastic cells from the mother's uterine endometrium.
And that stored iron in the liver, again about 1/3 of the total, is a critical physiological preparation.
It's a built-in buffer, yeah. Providing the neonate with enough iron for several months of hemoglobin production while they transition to external sources like milk, which might not be super rich in iron.
Vitamins are also essential, and the fetus's needs are equal to or even greater than in adults because they are actively building tissue. The source highlights some specific vitamin roles.
B vitamins, particularly B12 and folic acid, are fundamental. They're necessary for red blood cell formation, that critical nervous tissue development we discussed, and just overall growth, really basic building blocks.
Vitamin C is needed for forming intercellular substances, the glue that holds tissues together, especially important for the matrix of bone and connective tissue fibers. The source notes the fetus doesn't store much vitamin C.
So it relies on continuous supply from the mother. Breast milk is usually a good source unless the mother is deficient, but cow's milk has less. This is why vitamin C deficiency, scurvy, used to be a concern in infants fed only cow's milk without supplementation.
Okay, and vitamin D.
Vitamin D is vital for normal fetal bone growth, primarily because it's necessary for the mother to absorb calcium adequately from her own diet. If the mother has enough vitamin D, the fetal liver stores large quantities, providing the neonate with reserves for several months.
Vitamin E's role in early development isn't fully understood, but the source notes it's necessary for normal embryonic development, citing studies in lab animals where its absence is linked to spontaneous abortion.
And vitamin K is crucial for the fetal liver to produce essential blood coagulation factors, like factor VII and prothrombin. If the mother is vitamin K deficient, both she and the fetus will be deficient in these factors. The primary source of vitamin K for the mother is actually bacterial action in her colon.
And since a neonate doesn't have established gut flora for the first week or so, they lack this internal source of vitamin K.
Exactly. So that prenatal storage of vitamin K in the fetal liver is a critical physiological defense mechanism. It helps prevent bleeding, especially brain hemorrhage that could occur during the physical stress of birth. It's why vitamin K shots are standard practice for newborns.
Okay, we've built the system, we've fueled it, we've stocked its pantry. Now comes the most dramatic event, birth. This requires an immediate and radical physiological overhaul. Let's talk about the adjustments of the infant to extrauterine life.
This is the ultimate physiological test. The moment the umbilical cord is clamped, the baby loses its entire life support system, the placenta, which provided oxygen, nutrients, and waste removal. The primary and most urgent adjustment is simply beginning to breathe air.
And thankfully for most babies, this happens almost automatically, right?
Yes, breathing usually begins promptly, within seconds to maybe a minute after a normal delivery, without significant anesthetic interference. The source attributes the initiation to the sudden exposure to the exterior world. It's likely a combination of factors.
Like what?
Probably a combination of the slight transient asphyxia that naturally occurs during the birth process and the intense sensory stimulation, especially the sudden cooling of the skin. That cold shock is a powerful trigger to the brain's respiratory center.
And if that initial trigger isn't enough, if the baby doesn't start breathing right away,
If breathing doesn't start immediately, the resulting progressive hypoxia, low oxygen, and hypercapnia, high carbon dioxide, build up and provide an even stronger, more urgent stimulus to the respiratory center. This backup mechanism usually ensures breathing is triggered within another minute or so.
however, delayed or abnormal breathing is a serious concern, bringing the danger of hypoxia.
It is. And the source identifies factors that can interfere with this crucial first step. Maternal anesthesia, particularly general anesthetics, can depress both the mother and, consequently, the fetus, delaying the onset of spontaneous respiration in the baby. That's why minimizing anesthesia is often a goal.
Head trauma, or a prolonged, difficult delivery, can also cause slow or absent breathing. The source suggests two possible reasons, although one is less common.
Right. In rare cases, it could be intracranial hemorrhage or brain contusion causing a concussion effect that depresses the respiratory center. More commonly, though, the problem is prolonged fetal hypoxia during delivery.
Lack of oxygen in birth itself.
Yes. A lack of oxygen to the fetal brain during the birth process can seriously depress the respiratory center, making it slow to respond after birth.
What causes that delivery hypoxia?
The source lists several possibilities: compression of the umbilical cord, premature separation of the placenta from the uterine wall, excessive contraction of the uterus, which can constrict blood flow to the placenta, and even excessive maternal anesthesia, which can reduce the oxygenation of the mother's own blood being sent to the placenta.
It's remarkable that neonates seem to tolerate a lack of oxygen better than adults, up to perhaps 10 minutes compared to only about 4 minutes for an adult.
Yes, they have a higher tolerance, a bit more resilience, but it's definitely not unlimited. Permanent and serious brain impairment often follows if breathing is delayed beyond 8 to 10 minutes.
And the damage isn't random.
No, the source notes that the brain lesions resulting from this hypoxia tend to occur in specific areas like the thalamus and parts of the brainstem, which can permanently affect motor functions. This just highlights the critical urgency of those first breaths.
Okay, so breathing starts. But the lungs have to perform a seemingly impossible task, going from being fluid-filled and collapsed to air-filled and functional. Expanding the lungs at birth is a massive physiological effort.
It truly is. In utero, the tiny alveolar walls are collapsed, held together by the surface tension of the viscous fluid filling them. Overcoming this surface tension to inflate them for the first time requires immense force.
The source quantifies this force needed for the first breath, more than 25 millimeter Hg of negative inspiratory pressure. That's a significant vacuum the baby has to create with its tiny muscles.
And the first few breaths are even more powerful. A normal neonate's initial inspirations can generate up to 60 millimeter Hg of negative pressure in the intrapleural space. That force is necessary to pry open those collapsed, sticky alveoli.
Figure 84.3 really shows this dramatically. The pressure volume curve for the first breath is incredibly steep. You need a huge amount of negative pressure down to minus 40 centimeters of water, which is about minus 30 millimeter Hg, just to get a tiny bit of air in.
Yeah, and you have to go down to minus 60 centimeters of water just to get about 40 millimeters of air in. And then pushing that air back out, deflating, is also difficult. It requires considerable positive pressure, about plus 40 centimeter H2O, because of the resistance from the fluids still lingering in the smaller airways.
But look at the curve for the second breath, and subsequent breaths in that figure, it's dramatically different.
Much easier, yeah. It requires far less negative and positive pressure. This is because once the alveoli are opened, they tend to stay at least partially open, thanks partly to surfactant beginning to work.
The source notes that breathing doesn't become completely normal, with a compliance curve shape resembling adults until about 40 minutes after birth. It takes a while to settle down.
This difficulty in expanding the lungs leads us directly to one of the most serious problems faced by premature infants: respiratory distress syndrome, or RDS.
Right, this affects a subset of infants, notably premature babies, and those born to diabetic mothers. It presents a severe breathing difficulty in the hours and days after birth and can be life-threatening.
Pathologically, the lungs are stiff and wet. The alveoli are filled with proteinaceous fluid, essentially plasma, that has leaked out of the capillaries and shed alveolar cells. Under the microscope, this material can look like a glassy or hyaline membrane lining the alveoli.
Hence the older name hyaline membrane disease.
Exactly. The core physiological problem here is a failure to produce enough surfactant.
Surfactant. Explain that again.
Surfactant is a crucial substance secreted into the alveoli by specialized cells called type 2 alveolar epithelial cells. Its main function is to dramatically reduce the surface tension of the fluid lining the alveoli. Think of it like soap in a bubble.
Okay.
Without enough surfactant, that surface tension is very high, making it incredibly difficult for the alveoli to open during inspiration and causing them to collapse again during exhalation. It also contributes to the pulmonary edema, the fluid leakage, seen in this condition.
And why are premature babies particularly vulnerable to surfactant deficiency?
Because those type 2 alveolar cells that secrete surfactant don't begin significant secretion until the last 1 to 3 months of gestation. So a baby born too early simply hasn't had enough time to develop the capability to produce sufficient surfactant. Many premature babies and even some full-term infants lack this capability, leading to alveolar collapse, lung stiffness, and fluid leakage, the hallmarks of RDS.
Simultaneously with initiating breathing, the circulatory system must undergo an equally radical transformation. This isn't just breathing. The plumbing has to change too.
Absolutely. The entire pattern of blood flow, which was optimized for life connected to the placenta, must instantly switch to a pattern where blood flows through the baby's own lungs and liver. There's also an immediate increase in blood flow through the baby's liver in those first few hours.
To understand this change, you really have to understand the unique setup of fetal circulation. The source gives us figures, 84 to 4 and 84 to 5, and a detailed description of how blood bypasses the lungs and liver in utero.
Right. The fetal heart pumps a large volume of blood, but a significant portion, about 55% of the combined output in both ventricles, according to figure 84 to 5, is directed through the placenta. The placenta acts as the fetal lungs, gut, and kidneys, handling gas exchange, nutrition, and waste removal.
And only a small amount, about 12%, goes through the lungs.
Yeah, just enough to keep the tissue alive and developing, but not for gas exchange. It's mostly bypassed.
Let's trace that fetal pathway from figure 84 to 4. Oxygenated blood comes back from the placenta via the umbilical vein. Most of it bypasses the liver through a shunt called the ductus venosus.
And goes straight into the inferior vena cava, mixing with deoxygenated blood returning from the lower body. This mixed, but still relatively oxygenated, blood enters the right atrium.
But instead of all of it going to the right ventricle like in adults.
A significant portion of this more oxygenated blood from the IVC is directed across the right atrium through an opening in the atrial septum called the foramen ovale, directly into the left atrium.
So the best oxygenated blood gets shunted to the left side of the heart.
Exactly. From the left atrium, it goes to the left ventricle and is pumped into the aorta, primarily directed towards the head and forelimbs, ensuring the developing brain gets the best possible oxygen supply.
Smart routing. Meanwhile, what about the deoxygenated blood from the baby's upper body?
That returns via the superior vena cava to the right atrium. This blood is directed down into the right ventricle and pumped into the pulmonary artery.
But again, because the lungs aren't doing gas exchange and have high resistance.
Most of this deoxygenated blood in the pulmonary artery doesn't go to the lungs. Instead, it's shunted through another vessel, the ductus arteriosus, which connects the pulmonary artery directly to the descending aorta, bypassing the lungs.
So it joins the aortic blood flow going to the lower body.
Right. And from the descending aorta, this mixed blood flows down to the umbilical arteries, returning to the placenta to pick up oxygen and nutrients and get rid of waste. It's this ingenious, complex circuit designed specifically for placental dependence.
But at birth, this system has to change immediately. What triggers these changes? It seems so complex.
The primary triggers are actually quite simple. The loss of the placental blood flow when the cord is clamped, and the dramatic expansion and aeration of the lungs when the baby starts breathing. These two events radically alter the pressures and resistances in the circulatory system.
How do they change the pressures? Let's start with losing the placenta.
Losing the placenta instantly removes a huge, low-resistance vascular bed from the circulation. Imagine disconnecting a massive open hose from a pump system. This causes the systemic vascular resistance, the resistance to blood flow throughout the rest of the baby's body to approximately double.
Doubled resistance means higher pressure.
Exactly. Higher systemic resistance means higher pressure in the aorta, which in turn increases pressure in the left ventricle and, crucially, the left atrium.
Okay, left side pressure goes up. What about the lungs?
When the lungs expand and fill with air, several things happen simultaneously that lower resistance dramatically. First, the physical compression of the pulmonary vessels that existed because the lungs were collapsed is released. Second, the hypoxia that existed in the fetal lungs, fetal blood PO2 is only about 15-20 millimeter Hg, is eliminated by breathing air. PO2 jumps to around 100 millimeter Hg within hours. Hypoxia causes pulmonary vasoconstriction. Its removal causes vasodilation.
So the vessels open up physically and chemically.
Precisely. Together, these effects cause the pulmonary vascular resistance to plummet by as much as fivefold, according to the source. Lower pulmonary resistance means lower pressure in the pulmonary artery, the right ventricle, and the right atrium.
So after birth, you have high pressure on the left side of the heart and low pressure on the right side. This is the complete opposite of the fetal situation. And this is what drives the closure of the foramen ovale, that hole between the atria.
Exactly. With the pressure in the left atrium now significantly higher than in the right atrium, blood attempts to flow backward through the foramen ovale from left to right. But there's a small flap of tissue on the left side of the atrial septum that acts like a one-way valve over the foramen. The higher pressure in the left atrium pushes this flap closed against the septum, functionally sealing the opening and preventing blood flow between the atria.
And this functional closure happens almost instantly?
Pretty much immediately with the first breaths and pressure changes. The valve then usually becomes permanently fused to the septum over the following months to years in about 2/3 of people. Even if it doesn't permanently fuse, resulting in what's called a patent foramen ovale, or PFO, the normally higher pressure in the left atrium, typically 2 to 4 millimeters Hg greater than the right, keeps that valve functionally closed throughout life, unless there are unusual circumstances that raise right atrial pressure significantly.
Okay, so the foramen ovale closes due to pressure reversal. The ductus arteriosus, that bypass between the pulmonary artery and aorta, also closes, but through a different mechanism.
Yes, that's more of an active muscular contraction. With the increased systemic resistance raising aortic pressure and the decreased pulmonary resistance lowering pulmonary arterial pressure, blood flow through the ductus actually reverses direction after birth for a short time, flowing backward from the aorta into the pulmonary artery.
But then it shuts down.
Yes. The key event is that the muscular wall of the ductus arteriosus constricts markedly within a few hours to about 1 to 8 days after birth, stopping blood flow through it. This is the functional closure. Later, fibrous tissue grows in and permanently seals it, usually within 1 to 4 months.
What causes this muscular constriction?
It's strongly related to the increased oxygenation of the blood flowing through the ductus itself. Remember, fetal blood passing through the ductus had a very low PO2. After birth, the baby breathes air and the blood oxygen level rises dramatically. This high oxygen tension directly stimulates the smooth muscle in the ductus wall to contract and clamp down.
The source also mentions prostaglandins playing a role.
Right. It's thought that prostaglandins, specifically PGE2 produced by the placenta, help keep the ductus open dilated in utero. When placental blood flow ceases at birth, this source of vasodilating PGE2 is removed, contributing to the closure.
And if it fails to close?
That's a patent ductus arteriosus, or PDA, a common congenital heart defect. The source speculates this failure might sometimes be due to excessive dilation caused by prostaglandins. Interestingly, administering indomethacin, a drug that blocks prostaglandin synthesis, can often help trigger closure of a PDA in newborns.
Okay, one more shunt. The ductus venosus, that bypass around the liver, that closes too.
Yes. In the fetus, portal blood from the abdomen joins the oxygenated umbilical vein blood, and most of this combined flow shunts through the ductus venosus directly into the vena cava, largely bypassing the main filtering sinusoids of the liver. After birth, umbilical vein flow stops, obviously. Initially, some portal blood might still sneak through the ductus venosus.
But then it closes.
Yes, the source says the muscle wall of the ductus venosus contracts strongly within 1 to 3 hours after birth, functionally closing this shunt.
What's the result of that closure?
The result is that the pressure in the portal vein rises slightly, from near zero to maybe 610 millimeter Hg, and this forces all the portal blood to now flow through the liver sinusoids before reaching the general circulation. This is crucial because it allows the liver to begin its vital job of processing nutrients absorbed from the GI tract and filtering bacteria or toxins coming from the gut for the first time. The exact mechanisms causing this ductus venosus closure are noted as uncertain, though.
So that's the incredible physiological ballet of birth. Instantaneous switches in breathing and circulation, driven by radical shifts in pressure, resistance, and oxygenation. Amazing. But the challenges aren't over. The infant is now solely responsible for its own metabolism and needs. Let's talk about the nutrition of the neonate.
Right, the umbilical cord buffet is closed. Before birth, energy came almost entirely from glucose supplied continuously by the mother, but that supply is cut off instantly. The infant has stored some glucose as glycogen in the liver and muscles, but those stores only last for a few hours.
And as we noted earlier, the neonate's liver isn't fully mature, particularly its ability to perform gluconeogenesis, creating new glucose from other substances like amino acids or lactate.
Exactly. It hasn't quite got the hang of that yet. This is why blood glucose levels in the infant can frequently fall quite low on the first day, sometimes down to 30-40 milli-GDL, which is less than half the normal adult value.
So how does the baby get energy if glucose runs low and the liver can't make enough? That sounds dangerous.
Fortunately, the infant is metabolically flexible and equipped to switch fuel sources. They can readily utilize their stored fats and proteins for energy metabolism until the mother's milk becomes available in larger quantities, which typically takes 2 to 3 days to fully come in. Colostrum, the initial milk, provides antibodies and some nutrients, but the volume is small initially.
There's also a significant challenge with fluid supply, isn't there?
Yes, infants have a remarkably high fluid turnover rate. The source says about 7 times that of an adult relative to body weight. They process a lot of water relative to their size.
And that high turnover, combined with the delay in the mother's full milk supply developing, makes ensuring adequate fluid intake a real challenge in the first few days.
Which leads to that initial weight loss we see.
Right. The source says an infant's weight typically decreases by 5–10% and sometimes up to 20% in the first 2 to 3 days of life. Most of this loss isn't tissue mass, but fluid loss. It's a normal adjustment period.
It is, but it highlights their sensitivity to fluid balance.
Okay, so beyond just getting nutrients and fluid in, the neonate faces a host of special functional problems, stemming largely from the immaturity of their control systems.
That's the core characteristic the source emphasizes, the instability of hormonal and neurogenic control systems. Things are just not fine-tuned yet. This instability comes from both the incomplete development of many organs and the fact that these systems haven't yet learned or adjusted to regulating everything independently in the completely new extrauterine environment.
Let's look at the respiratory system again. We talked about the drama of the first breath, but what about normal breathing and the neonate? How does it compare?
Well, the normal respiratory rate is quite high, around 40 breaths per minute. Tidal air, the volume per breath, is small, averaging only about 16 milliliters. This gives a minute respiratory volume of 640 milliliters per minute. Compared to body weight, this is about twice as high as an adult's minute ventilation. They're breathing fast and often.
But their functional residual capacity, FRC, the air left in the lungs after a normal breath, the buffer volume is low, only about half that of an adult relative to body weight.
And this low FRC is potentially a problem. That residual air normally acts as a buffer, smoothing out variations in blood oxygen and carbon dioxide levels between breaths. With a low FRC, if the baby's breathing rate slows or becomes irregular, it can cause exaggerated cyclical swings in blood gas concentrations.
Making them more vulnerable to drops in oxygen or rises in CO2.
Exactly. Less stability in the system.
The circulatory system also has unique characteristics in the neonate. Blood volume.
Blood volume immediately after birth is about 300 milliliters. The source mentions an interesting point. If the umbilical cord is stripped towards the baby to push extra blood in before clamping, or if cord clamping is delayed for a few minutes, an additional 75 milliliter can enter the baby, raising the initial volume to about 375 milliliter.
What happens to that extra volume? Does it stay?
Not entirely. Over the next few hours, fluid shifts from the bloodstream into the tissue spaces. This actually increases the hematocrit, the concentration of red blood cells in the blood that remains, but brings the total blood volume back down towards the 300 milliliter baseline.
Is getting that extra blood good or bad?
There's some debate. The source notes it might potentially contribute to mild pulmonary edema or respiratory distress in some cases, but the extra red blood cells and the iron they contain are generally seen as beneficial, especially for preventing later anemia.
Cardiac output is also very high relative to body weight.
Yes, averaging 500 milliliters per minute, again, about twice an adult's relative to size, reflecting their high metabolic rate. Low cardiac output can be a problem if there was significant blood loss from the placenta at birth.
And blood pressure starts low and climbs slowly.
Yeah, on the first day, it averages around 70 millimeter Hg systolic over 50 millimeter Hg diastolic. It rises slowly over the next several months to about 960 millimeter Hg and then much more gradually over years, only reaching typical adult pressures around adolescence.
Blood characteristics are also interesting. The red blood cell count is relatively high at birth, averaging about 4 million per cubic millimeter, potentially rising even higher initially with that extra cord blood.
But then the source points out something counterintuitive. Few new red blood cells are formed in the first few weeks of life.
Why is that?
It's likely because the strong hypoxic stimulus of fetal life, which drove rapid RBC production, is suddenly gone now that the baby is breathing oxygen-rich air. As a result, as shown in figure 84-6, the red cell count gradually falls below 4 million by 6 to 8 weeks of age. This is called physiological anemia of infancy.
But it's normal.
It's considered normal, yeah. Then, the increasing activity levels as the baby gets older provide a new stimulus for RBC production, and the count returns to normal within another 2-3 months. White blood cell counts, interestingly, are extremely high immediately after birth, around 45,000 per cubic millimeter, which is about 5 times an adult's count. A big inflammatory-like response to birth, perhaps.
A very visible and often concerning issue in neonates is jaundice, that yellowing of the skin.
Right. During fetal life, the baby's liver isn't fully functional for processing bilirubin, which is a yellow breakdown product of old red blood cells. But that was okay because bilirubin could easily cross the placenta to the mother's liver, and her liver would excrete it.
But after birth, the baby's own liver has to take over this job.
Yeah. And for the first week or so, its function is still immature. Specifically, it's not very good at conjugating bilirubin with glucuronic acid. Conjugation is a necessary step to make bilirubin water-soluble so it can be excreted into bile and eliminated.
So, because the liver can't process it fast enough, unconjugated bilirubin builds up in the blood.
Exactly. Figure 84-6 shows plasma bilirubin rising from typically less than 1 milligdl to an average of 5 milligdl over the first 3 days. This causes physiological hyperbilirubinemia, which manifests as mild jaundice, that yellow tinge to the skin and the whites of the eyes, usually lasting for 1 to 2 weeks.
And this is usually harmless.
This physiological jaundice is common and typically harmless, yes. It resolves as the liver matures. However, the source emphasizes that the most important abnormal cause of serious neonatal jaundice is erythroblastosis fetalis.
Which is usually due to Rh factor incompatibility.
Primarily, yes. This is where an Rh-negative mother becomes sensitized, usually during a previous pregnancy or delivery, to the Rh factor present on her Rh-positive baby's red blood cells. She produces antibodies against the Rh factor. These antibodies can cross the placenta in a subsequent pregnancy and attack and destroy the Rh-positive fetus's red blood cells.
And that massive destruction of red blood cells releases huge amounts of bilirubin.
Exactly. Far more than the immature liver can handle. This can cause severe jaundice. If bilirubin levels get extremely high, the unconjugated bilirubin can cross the immature blood-brain barrier and cause bilirubin toxicity in the brain, known as kernicterus, which can lead to permanent neurological damage or even death. The source notes that before modern treatments like RhoJam shots and exchange transfusions, mild or serious cases occurred in maybe 1 in 50 to 100 neonates. Much rarer now, thankfully.
Okay, let's talk about fluid balance, acid-base balance, and kidney function. These seem tightly linked and problematic.
They are intimately linked, and they pose significant challenges for the neonate precisely because of the system immaturities we've touched on.
We already mentioned the high fluid turnover rate 7 times in adults relative to weight. High throughput.
which means even small errors in fluid intake or unexpected losses, like from vomiting or diarrhea, can lead to rapid and severe dehydration, or, conversely, fluid overload if intake is excessive. There's less room for error.
Compounding this is the high metabolic rate, twice that of an adult relative to body mass.
And a high metabolic rate produces more metabolic acids as byproducts. So, relative to their size, they produce twice as much acid as an adult, giving them an inherent tendency towards acidosis.
And the kidneys, which are supposed to regulate fluid, electrolytes, and excrete that excess acid, are still quite immature. They don't reach full functional maturity until about the end of the first month.
Their concentrating ability is particularly limited. Neonate kidneys can only concentrate urine to about 1.5 times the osmolality of plasma, whereas an adult kidney can reach 3 to 4 times drachma osmolality.
Meaning they are less efficient at conserving water when needed or excreting a concentrated load of waste.
Exactly. So you have this perfect storm, really. High fluid turnover demanding precise balance, rapid acid production pushing towards acidosis, and immature kidneys that struggle to compensate by conserving water effectively or excreting acid efficiently. This combination makes acidosis, dehydration, and electrolyte imbalances major potential problems in infancy.
The liver's general immaturity in the first few days also impacts several critical functions beyond just bilirubin processing.
Yes, the source lists several key deficits. We covered the poor bilirubin conjugation and excretion, also deficient plasma protein formation.
Plasma protein levels can be lower.
Plasma protein concentration can be 15–20% lower than in older children during the first weeks. While often not clinically significant on its own, in some cases, this can contribute to hypoproteinemic edema swelling caused by low protein levels in the blood reducing osmotic pressure.
The liver's gluconeogenesis is also particularly deficient.
Right, contributing to those potentially low blood glucose levels in unfed infants, forcing reliance on fat stores for energy.
And importantly, the neonate liver usually produces too little of the blood coagulation factors needed for normal blood clotting, increasing the risk of bleeding.
This is separate from, but additive to, the potential vitamin K deficiency issue we discussed earlier. Both can contribute to bleeding risk in the newborn.
Okay. In terms of digestion, absorption, energy metabolism, and overall nutrition, the neonate is functionally similar to an older child in many ways, but with specific limitations noted.
Yes. For example, pancreatic amylase secretion is deficient. Amylase breaks down starch. So neonates are relatively poor at digesting and utilizing complex carbohydrates like starches initially.
Absorption of fats is also somewhat less efficient than later in life. The source notes that high-fat milk, like unmodified cow's milk, is often inadequately absorbed compared to human milk, which has fats that are easier to digest.
And as we emphasize, blood glucose levels can be unstable due to the liver's imperfect regulatory function in the first week or so.
On the plus side, though, infants are remarkably efficient at protein synthesis.
They really are. With an adequate protein intake, the source says up to 90% of the ingested amino acids are used for building body proteins. That's a much higher percentage than in adults, reflecting the incredible rate of tissue growth happening in infancy.
The neonate's high metabolic rate also interacts with their ability or inability to regulate body temperature effectively.
Right. The metabolic rate relative to body weight is twice that of an adult, meaning they generate a lot of heat per unit of body mass. However, they also lose heat very readily.
Why do they lose heat so easily?
Because they have a relatively large body surface area compared to their small body mass. More surface area means more area for heat to radiate or convect away into the cooler environment.
This makes them prone to temperature drops, especially right after birth. Figure 84-7 shows that even normal infants can see their body temperature fall several degrees Fahrenheit in the first hours after birth, although it typically returns to normal within 7–10 hours if they're kept warm.
But their temperature regulation mechanisms are generally poor in the early days. They just don't have the sophisticated shivering or non-shivering thermogenesis responses fully developed, leading to marked temperature deviations if not carefully managed environmentally.
The source highlights that a body temperature falling below 96 degrees Aero, that's 35.5 degrees, is associated with a significantly high death rate.
Which is why maintaining a stable, neutral thermal environment, often using incubators or radiant warmers, is absolutely crucial, especially for premature or otherwise vulnerable infants. You have to protect them from heat loss.
Considering all these factors, there are specific nutritional needs and vulnerabilities in the early weeks that need attention.
Yes. Assuming the mother's diet was adequate, a neonate is typically born in complete nutritional balance, and their GI system is generally capable of absorbing nutrients if the right kind are provided. But there are three particularly important considerations early on mentioned in the source.
Calcium and vitamin D.
Critical for that rapid bone ossification that's happening. Milk provides calcium, but vitamin D is absolutely essential for the baby to absorb that calcium from the gut. Without sufficient vitamin D, severe rickets can develop very quickly, within weeks. This is even more of a risk in premature babies who are even less efficient at absorbing calcium. So, close attention to adequate vitamin D intake, often through supplements, is required.
Iron is also key.
Yes. If the mother had sufficient iron stores during pregnancy, the infant usually has enough iron stored in their liver to last for about 4 to 6 months. But if maternal iron status was poor, the infant stores will be low, and severe iron deficiency anemia can develop in the infant after about 3 months, once those initial stores run out. The source suggests early feeding of iron-rich foods like egg yolk or iron supplementation might be recommended by 2 to 3 months in such cases.
And vitamin C.
Vitamin C isn't stored significantly by the fetus, so they rely on ongoing intake. It's needed for the structural integrity of cartilage, bone, and other connective tissues. Breast milk is usually adequate unless the mother herself is severely deficient, but traditional cow's milk formulas used to be low in vitamin C. Supplementation may be needed if deficiency is a risk.
Immunity is another vital area of concern in the neonatal period.
They seem so vulnerable.
They are, in terms of their own immune system, which isn't fully developed at birth. However, they inherit significant passive immunity from their mothers. Many maternal protein antibodies, particularly IgG antibodies, are actively transported across the placenta during gestation.
So they get mom's antibodies.
Yes, providing them with a substantial degree of protection against many common childhood diseases that the mother is immune to, like diphtheria, measles, and polio, for roughly the first 6 months of life. It's a temporary shield.
But the infant's own immune system doesn't start producing antibodies in significant amounts immediately. No, it takes time to ramp up. As a result, those maternal antibodies inherited from the mother gradually decline in the baby's bloodstream. By the end of the first month, the baby's gamma globulin level, which contains these antibodies, is less than half the original level at birth, and their passive immunity decreases accordingly over the next few months.
The baby's own immune system then gradually takes over.
Exactly. It starts forming its own antibodies, with gamma globulin concentrations returning essentially to normal adult levels by around 12 to 20 months of age.
This timeline is key to immunization schedules, right?
Absolutely. Immunization against diseases for which inherited maternal immunity is typically strong, like measles, isn't usually necessary before 6 months because the maternal antibodies would interfere anyway. But for diseases where maternal antibody transfer isn't as effective or long-lasting, like whooping cough, pertussis, immunization is needed earlier, typically starting around the 2nd month. The source mentions the DTaP vaccine schedule as an example, starting early.
It's also interesting that allergy is relatively uncommon right at birth.
Yes, neonates seldom experience significant allergies initially. But several months later, once their own antibody-producing system becomes more active and mature, sometimes extreme allergic states can develop.
Manifesting as
Severe eczema, significant gastrointestinal problems related to food allergies, or even potentially life-threatening anaphylaxis in some cases.
these often get better.
The source notes these allergic manifestations often tend to disappear or lessen as the child gets older and develops higher degrees of overall immunity, suggesting a complex, dynamic interplay between the developing immune system and allergic reactivity. It's not fully understood.
Finally, let's briefly touch on endocrine problems. The source says these are usually rare at birth, but highlight some specific important circumstances.
Right. The endocrine system itself, the glands producing hormones, is generally quite well developed at birth, so immediate hormonal abnormalities are uncommon compared to, say, kidney or liver immaturity.
But there are scenarios where maternal conditions or external factors can impact the fetal endocrine system.
Yes. For instance, if a pregnant mother is treated with androgenic hormones, male-type hormones, or has a rare androgen-producing tumor, a female fetus can be exposed to excess androgens. This can lead to masculinization of her external sexual organs, resulting in a condition sometimes referred to as a type of hermaphroditism or, more currently, an intersex variation or disorder of sex development.
Maternal and placental sex hormones can also have temporary effects.
Yes, the high levels circulating during pregnancy can sometimes stimulate the neonate's breast tissue, occasionally causing them to secrete small amounts of milk, sometimes called witch's milk, in the first few days of life. This can sometimes lead to mild inflammation or mastitis in the baby's breast tissue, but it's usually transient.
An infant born to an untreated diabetic mother presents a classic endocrine challenge.
Particularly with maternal type 2 diabetes or gestational diabetes, where the mother has high blood glucose. The fetus is exposed to these high glucose levels, which constantly stimulates its own pancreas to produce excess insulin. This leads to hypertrophy, enlargement, and hyperfunction overactivity of the fetal pancreatic islets that make insulin.
What happens after birth?
After birth, the maternal glucose supply is suddenly cut off, but the baby's pancreas is still overproducing insulin. This can cause the infant's blood glucose to fall dangerously low, often below 20 milligdl shortly after birth, a state called hypoglycemia.
While potentially serious, the source notes that actual insulin shock or coma is rare in neonates compared to adults, thankfully. Maternal type 2 or gestational diabetes is also a common cause of macrosomia, or very large babies.
And this isn't just due to the extra glucose and nutrients crossing the placenta. The excess fetal insulin itself acts as a potent growth factor, stimulating overall fetal growth, especially fat accumulation, and potentially causing enlargement of organs like the heart and liver.
In contrast, if a mother has uncontrolled type 1 diabetes where she lacks insulin,
The situation can be quite different. The maternal metabolic deficits can actually stunt fetal growth. The neonate may be born small and have stunted tissue maturation. There's also a high risk of intrauterine mortality. Even among those born at term, there's a high mortality rate, with the source stating 2/3 potentially succumbing to respiratory distress syndrome, likely due to delayed lung maturation associated with the abnormal maternal metabolic environment.
other rare endocrine issues mentioned include infants born with hypofunctional adrenal cortices, underactive adrenal glands, possibly due to lack of development, agentesis, or maybe exhaustion atrophy from prior overstimulation in utero.
Maternal thyroid issues can also temporarily impact the infant. If the mother has hyperthyroidism or takes excess thyroid hormone, it can cross the placenta and suppress the infant's own thyroid, leading to temporary hyposecretion after birth. Conversely, if a mother had her thyroid removed before pregnancy, her pituitary might secrete excess thyroid-stimulating hormone, TSH, which can cross the placenta and could potentially cause temporary hyperthyroidism in the infant.
And critically, severe lack of fetal thyroid hormone secretion leads to poor bone growth and significant mental retardation. The condition historically known as cretin dwarfism, now congenital hypothyroidism. This highlights the absolutely essential role of thyroid hormone for normal brain and skeletal development early in life.
This really leads us to perhaps the most challenging group overall, premature infants. As the source starkly notes, pretty much all the neonatal problems we've discussed are severely exacerbated in infants born prematurely.
They categorize the challenges into two main areas.
Yes. First, the inherent immaturity of certain organ systems simply because they haven't had enough gestational time to develop fully. And second, the resulting extreme instability of their homeostatic control systems because those immature organs can't regulate things properly.
Modern medicine has made incredible strides here, though.
Absolutely. The source notes that the survival rate for extremely preterm infants, those born at less than 28 weeks gestation, is now remarkably high, around 80–90% in centers with modern neonatal intensive care, (ICU). However, survival rates still decline significantly with each week earlier they are born, and survival below about 22 weeks gestation is still unfortunately very rare.
Let's look at the most critical immature organ systems in premature infants that require particular attention in the NICU. Respiration is a major one.
Huge challenge, especially for the most premature. Their vital capacity and functional residual capacity, FRC, are incredibly small relative to their size. And as we discussed, surfactant secretion is often severely depressed or completely absent, making respiratory distress syndrome, RDS, a primary cause of illness and death in this group.
And that low FRC also causes breathing instability.
Yes, it predisposes them to periodic breathing, or even Cheyne-Stokes breathing those patterns of alternating rapid breaths and pauses, apnea, because they lack that buffering capacity in their lungs.
Gastrointestinal function is also a significant problem.
Major problem, particularly for babies born more than 2 months prematurely. Their digestive and absorptive systems are often grossly inadequate, making feeding very difficult. They often have poor fat absorption, requiring special formulas with easier-to-digest fats.
And calcium absorption is also poor.
Yes, they have marked difficulty absorbing calcium, meaning severe rickets can develop very quickly if intake isn't sufficient. Special attention to providing adequate calcium and vitamin D is essential.
Other organ immaturities create further risks. The liver.
An immature liver leads to poor intermediary metabolism, difficulty handling fats, proteins, glucose, poor synthesis of plasma proteins leading to edema, and a significant bleeding tendency due to inadequate production of coagulation factors.
Immature kidneys.
Particularly deficient at ridding the body of acids, which severely predisposes premature infants to metabolic acidosis and makes maintaining fluid and electrolyte balance incredibly precarious.
And the blood-forming system.
An immature bone marrow, their blood-forming mechanism, means they are prone to rapid development of anemia. And depressed gamma globulin formation by their immature lymphoid system makes them highly susceptible to serious, potentially overwhelming infections. All this organ system immaturity directly results in the second category of problems, the extreme instability of their homeostatic control systems. Things fluctuate wildly.
Like acid-base balance.
Can vary tremendously, especially with variations in feeding, respiration, or temperature. Blood protein levels are typically low due to the immature liver, often leading to that hypoproteinemic edema.
Calcium regulation is unstable.
Yes, their inability to precisely regulate calcium ion concentration makes them vulnerable to hypocalcemic tetany, muscle spasms, and irritability caused by low blood calcium. And blood glucose can swing extremely from very low, maybe 20 mg/dL, to quite high, over 100 mg/dL, depending mainly on the regularity of feeding and the liver's fluctuating ability to manage glucose.
Instability of body temperature is perhaps the most visible challenge for preemies.
Absolutely. Premature infants simply cannot maintain their own body temperature effectively. It tends to drift towards the temperature of their surroundings because of that high surface area to mass ratio and poor regulatory mechanism.
They can get very cold easily.
At normal room temperature, their body temperature might stabilize in the low 90s or even 80s Fahrenheit. Since, as we mentioned, a temperature below 96 degrees F, 35.5 degrees F, is linked to a high death rate, keeping them in a carefully regulated warm environment like an incubator is not just helpful, it's virtually mandatory for survival.
Finally, the source mentions a specific, tragic danger associated with premature infants and their respiratory issues. Blindness caused by excessive oxygen therapy.
Yes, this is known as retinopathy of prematurity, ROP. Oxygen therapy is often essential to help these babies breathe because their lungs are immature and surfactant deficient. However, it was discovered that using excessive concentrations of oxygen, especially in very premature infants, can paradoxically interfere with normal retinal development. It actually stops the normal, orderly growth of new blood vessels in the retina.
The problem arises when the oxygen therapy is eventually stopped or reduced.
Exactly. The retina, now suddenly sensing it lacks adequate blood supply, relative hypoxia, triggers an explosive, excessive, and chaotic growth of new, abnormal blood vessels. These vessels grow aberrantly, often into the vitreous humor, the clear gel filling the eye, causing scarring and potentially retinal detachment, blocking light from reaching the photoreceptors.
And this leads to blindness.
Later, these abnormal vessels are often replaced by opaque fibrous tissue right where the clear vitreous humor should be. This condition, historically called retrolental fibroplasia, leads to permanent visual impairment or blindness.
A devastating complication from trying to help them breathe.
It is. It was a major cause of childhood blindness until the connection with excessive oxygen was made. Prevention now involves very careful monitoring of oxygen levels, aiming to use the lowest concentration needed to maintain adequate but not excessive blood oxygenation. The source suggests physiological studies indicate relative safety up to perhaps 40% oxygen, though some child physiologists advocate for keeping oxygen as close to normal air concentration, 21%, as possible for complete safety whenever the infant's condition allows. It's a constant balancing act.
We focused heavily on the fetal and immediate neonatal period because that's where the most dramatic transformations and acute challenges occur. But development obviously continues beyond the neonatal period. Let's briefly touch on growth and development in the child as outlined.
Right. The source notes that the major physiological problems in later childhood are often related to the special metabolic needs of ongoing growth and are covered more extensively in other sections of a typical physiology text, particularly those dealing with metabolism and endocrinology, like hormones influencing growth.
But we can look at height growth, which is depicted in figure 84-8. Interestingly, boys and girls follow very similar height growth curves until about the end of the first decade, around age 10. They track pretty closely.
Then puberty hits, and sex hormones kick in, causing the paths to diverge significantly. In females, rising estrogen levels around 11-13 years cause a rapid growth spurt. But estrogen also causes the epiphyses, the growth plates, at the ends of long bones to fuse with the main shaft of the bone relatively early, typically around 14, 16 years. Once those epiphyses fuse, longitudinal bone growth stops, and growth in height ceases.
In males, testosterone causes a growth spurt slightly later, mainly between ages 13 and 17. But testosterone allows for a more prolonged period of growth before the epiphyses eventually fuse, usually later than in girls. This longer growth period is the main reason why males, on average, end up taller than females.
Behavioral growth in childhood is intimately linked to the continuing maturation of the nervous system. Though, as the source acknowledges, it's often challenging to completely separate this underlying anatomical and physiological maturation from the undeniable effects of training, learning, and environment, nature and nurture interacting.
We noted earlier that some major CNS tracts aren't fully myelinated until the end of the first year. The cerebral cortex itself and complex functions like visual processing require several months or even years postnatal to reach final functional development.
Brain mass growth continues rapidly after birth, reaching about 55% of adult size at 1 year and nearly adult proportions by the end of the second year. And as noted earlier, the skull size then limits further brain growth to only about 20% additional beyond age 2. Most of the physical growth is done early.
Figure 84-9, that behavioral progress chart for the first year showing milestones like sitting, crawling, walking, is mentioned as a practical tool used clinically.
Yes, it helps assess a child's mental and behavioral growth against established norms, providing a tangible way to track this critical neurological development and identify potential delays that might warrant further investigation. It connects the underlying physiology to observable function.
Wow, what an absolutely incredible deep dive. We've journeyed from literally a microscopic beginning, traced the astonishing rapid unfolding of all the complex organ systems, navigated the truly radical physiological adjustments required in the minutes and hours after birth, and looked at the critical, often vulnerable, first months and years of growth and adaptation.
It really is a process defined by intricate coordination, delicate balances, and frankly, remarkable resilience when you consider everything that has to go right. Understanding these physiological principles at this level really gives you a profound appreciation for the sheer engineering marvel that is human development and also for the challenges involved, especially when the process is disrupted by things like prematurity.
Absolutely. Think about the precision required for those fetal shunts, the foramen, ovale, and ductus arteriosus, to close right on cue, or the immense force of those first breaths battling surface tension, or the fragile balance needed for fluid and electrolytes with immature kidneys, or the critical timing required for surfactant production to allow breathing in the first place. It's not just a list of biological facts. It's a breathtaking story of biological adaptation and vulnerability.
It really highlights how interconnected everything is and how problems in one system, like immature lungs, can cascade and affect others. Gaining this level of detailed physiological understanding provides a powerful lens through which to appreciate not only the miracle of normal birth, but also the complexity of the medical care required to support infants when these natural processes don't go perfectly according to the physiological blueprint.
What stands out to you most from this deep dive? How does seeing this journey broken down into its intricate physiological components change your perspective on the earliest stages of life and development?
For me, it's the realization of how much critical development continues after birth and how dependent the infant remains on meticulous physiological control, much of which is still maturing. We think of birth as the endpoint of development, but in so many ways, especially neurologically and immunologically, it's just the beginning of another incredibly complex phase. And it underscores the lifelong implications of events during this period, how things like birth hypoxia or nutritional deficiencies early on can potentially cast very long shadows.
That's a powerful thought. The foundation laid during this time truly shapes the future. Thank you for joining us on this extensive deep dive into the fascinating, complex world of fetal and neonatal physiology. Until next time.